Good morning, everyone. It is 9 o'clock, and to respect everyone's time, we're going to get started. I'm sure we'll have a few stragglers as we continue, but it looks like it'll be a pretty full meeting of around 40 people RSVP'd. Yes, so hopefully we see everybody today. I want to say it's so great to see your faces. If you have a camera and can turn it on, it would be great to see you. We haven't been able to connect in person in a couple of years. We hope to do that soon. Hopefully our next TAC meeting, at least the option for a hybrid meeting would be great. So until then, we'll have to deal with virtual meetings for at least one more meeting. But thank you again for those of you who can turn your cameras on. For those of you who don't know me, my name is Melissa Josefiak. I am the Biomonitoring New Hampshire Program Specialist, and I'll be facilitating the meeting today. Just a couple of quick housekeeping items. If you haven't noticed, the meeting is being recorded. We'll have that available along with all slides sometime after the meeting. Lucy Soares, thank you very much for taking minutes today. And Katrina Maglio, one of our biomonitoring toxicologists, will be monitoring the chat so we don't miss any of your questions and ideas. So feel free to utilize that if you don't have time to speak up or just can't get a word in or would prefer to send in a chat message. Okay, so with that, we'd like to begin the meeting by welcoming with a welcome from Dr. Madhumita Chatterjee. Madhu, I'm going to pull up your slides right now. She's the new chemistry section manager for the New Hampshire Public Health Laboratories. So here we go.
Thank you, Melissa.
There we go.
So good morning, everyone. A very warm welcome to the Spring 2022 Technical Advisory Committee meeting. I am Madhumita Chatterjee. Can you guys hear me okay?
Yes.
Okay. So I go with Madhu, and on behalf of the biomonitoring team today, I would like to welcome you all to this meeting. I am the chemistry program manager, and I'm trying to fill in the shoes for Dr. James Chithalan for the last 6 years. Even though I might be new to some of you here today, my association with the New Hampshire Public Health Labs does span over the last 19 plus years. I started as a toxicologist at the biomonitoring program way back in 2003. Some of you might be in elementary and middle school then. So at that time, we were trying to set up the lab to get these new biomonitoring lab methods. In fact, when I was interviewed for the program, those instruments were still in the loading dock, and I was shown those instruments that had to be up here. Thereafter, in 2010, I moved into the food chemistry program and have enjoyed being the toxicologist there, analyzing very similar analytes of interest, but the matrix was in food samples. A short introduction regarding my educational qualification. After my degree in chemistry from India, I did work on biomonitoring the silver workers on the other side of the globe. So in India, these folks were working in very small constrained spaces with high fumes. So we were monitoring their levels of lead in the blood. Thereafter, that work did lead me to the College of Pharmacy at Ohio State. And from then on, New Hampshire has been my home for the last 22 years. So enough about me. You can move to the next slide, Melissa. So today, the entire biomonitoring crew has been extremely busy trying to get some of those projects off the ground, the new projects, since we met at our last technical advisory meeting in June of 2021. We will hear those new changes along with all the accomplishments and updates from the group. I wanted to touch base on the TRACE 2019 study. So TRACE is the Tracking and Assessment of Chemical Exposure study that was conducted here in our lab, and it covered the entire New Hampshire, all the way from Nashua to Pittsburgh and everywhere in between. You guys can see all the testing that was done. So blood, serum, and urine from 336 people was tested for 50 different analytes. Water samples from 274 households was tested for hundreds of chemicals. Next slide, please. So this picture does show the bright smile of each one of us as we concluded the study in October of 2021. We have our entire biomonitoring team along with our collaborators from the Environmental Public Health Tracking as well as USGS as we had this celebration. Next slide, please. So the TRACE study reports can be requested by emailing us, and this picture, even though we are masked up, does show the close collaboration we have within the internal teams here in the Department of Health and Human Services, along with our external collaborators. So environmental public health tracking not only helped us in translating the results of the TRACE study into easy to read reports, but they also helped in the heavy lifting of disseminating these reports. So you guys can see all those envelopes that were mailed to all the participants. So we are really thankful for this help that the team has got throughout the study period. Next slide, please. So the TRACE study was finalized, the results were released to participants, and the data was presented at multiple meetings, including 2 New Hampshire Legislative Committee meetings. The summary report was very thorough. In fact, it was the first of its kind that we are aware of, which contained biomonitoring and environmental water results. So if any of you are interested to look at the summary report, it can be downloaded from our website. And if you guys are interested, we could share that link, which I think we've done in the past, but we can't do so. Next slide, please. So once again, thank you all for the support and collaboration you guys have provided over the past years. We hope to continue that team effort as we move forward. And of course, we do hope to see you all in person at the next TAC meeting. So with that, I'll hand it over to our biomonitoring program specialist, Melissa. Take it on, Melissa.
Thank you, Madhu. And thank you for reminding us of the TRACE study. It feels like so long ago now. So it's nice to have that reminder of the work we did. Let's see, let me just stop sharing my screen. Next, I'd like to introduce Amanda Kosser, our biomonitoring program administrator, who will be providing an overview of our most recent study. Mandy, please let me know if you can't share your screen.
You should be able to see it now. All right, just trying to get it to go into presentation mode. You see that? Okay, great. Okay. So I will go ahead and get started. So this is our current study. This is called the Empower You Study, or Evaluating Metals in Private Wells in People for Exposure Reduction Uranium. You just saw this picture, but biomonitoring strength comes from our proud history of collaboration. So we collaborate very often with academia, state, and national programs, with many of you all here on our technical advisory committee. And that's how our program continues to grow, succeed, and help meet the needs of New Hampshire residents. And so one of those recently identified needs related to the assessment of natural uranium and groundwater contamination in New Hampshire, in particular private well water quality and body burden, those utilizing that private well water at home. So through partnership with the U.S. Geological Survey and a subgroup of BioMonitoring New Hampshire TAC members, the Evaluating Metals in Private Wells in People for Exposure Reduction Uranium, or Empower You study came to fruition. I'll show you this big black box in just a second. So we first introduced you to the Empower You study at last June's TAC meeting, during which time we referred to it as the uranium study. We were still in the initial study design stage at that time, so we didn't have very many details to share. That fall, study design progressed rapidly, which we'll share more details on shortly. BioMonitoring New Hampshire was asked to create a PetraCucha style presentation for our program update this past January at the National Biomonitoring Meeting. And one of our toxicologists here at the New Hampshire Public Health Labs, Katrina Maglio, took the lead on that. So she centered her update on the Empower You study through her lens as a new hire to our program. And she provides such a great overview of the study, as well as how our team generally progresses through biomonitoring studies. So I'm going to play that presentation for you now. Please interrupt if you can't hear it. I'm sorry?
We're just seeing one slide. There's nothing moving. You may have to share a new screen.
Okay.
I think we just couldn't hear the video, Mandy, because I know it stays on that slide for a while. I think we just weren't hearing the audio.
Okay, well, we have a different way to get to this. So let's try it this other way. Can you hear it now?
Still can't hear it, Mandy.
Well, that's unfortunate. Okay, so we will move on, and I can email this to you so you can watch it later, because it is such a great presentation. But my slide set still goes over all of the accomplishments and things that we had to do to progress with this study. So we will just skip to the next slide. And let me go back to screen presentation mode here. Okay, so an overview of our study here. So we were approached by the U.S. Geological Survey to see if we would be able to support a project evaluating a new uranium groundwater contamination risk model. And through a conversation between the U.S. Geological Survey and the National Center for Environmental Health, through which BioMonitoring New Hampshire is funded, we were also asked if this project was something we would be interested in supporting. So recognizing the significance to the health of New Hampshire residents and already having relationships in place, we decided to replace a different private well population project with this one. Some of the clinical and environmental analytes are listed here, but I'll go into more detail on those in a few slides. How did we determine our target population? So what we did was utilize the USGS radon risk model, which is here on the left, with real private well data from our partners at the New Hampshire Department of Environmental Services and here at the Division of Public Health Services. So real private well uranium results. So the risk model here on the left shows the probability of radon uranium above 1 microgram per liter in groundwater, with, you know, the higher the probability, the darker, you know, the color, the more red. And on the right there is the heat map of the real water results. So we did this to identify our 10 targeted recruitment areas. So the maps were overlaid with help from New Hampshire Division of Public Health Services GIS analyst Tyler Young. The team then identified 10 areas of recruitment with a goal of 20 homes from each area and as many residents as possible from within the homes with a lower age limit of 3 years old in order to ensure urine could be collected from the participant. The size of the various target areas are inversely related to population density. Tyler then plotted private wells on the maps to capture those addresses as well as public water system distribution lines. Homes that appeared to be connected to a public water system distribution line were then removed from our recruitment mailing list. And those physically far from the lines but not already captured by the private well database that we utilize were added back into the data set because we know that our state's private well database is incomplete for a number of reasons. So these are our 10 targeted areas, and all of the cities and towns are listed here. You know, pretty decent geographic distribution across the state. We have some areas farther north, which are always more difficult to recruit from. We decided to test only urine for this study as far as our biomonitoring part of the project. Although blood metal testing would have provided some really interesting information, especially since our 2019 surveillance study showed us that New Hampshire residents with private wells at home have a significantly higher blood lead level than those who have public water at home. But the logistics of phlebotomy and proper processing of blood specimens really complicate the collection process. And we had a really rapid recruitment with this study, so we opted for urine only. The metals on this slide are included in our urinary metals panels and arsenic speciation and urine panels adapted from CDC methods. We will be sending urine specimens to a contracted hospital for creatinine testing, and we're still exploring whether other health biomarkers would be of interest to our program, our partners, and our participants. The majority of water samples were collected by the resident. However, 50 participants also received home visits by USGS water samplers. This page lists all of the possible analytes tested for in water. However, the panel differed based on sample type. Finished water collected by the participant, like at their kitchen faucet, versus raw water collected directly from the well by USGS water samplers. We also tested air in this study. This was the first time we had an air testing component. And so home air testing was provided by the New Hampshire Environmental Public Health Tracking Section through contract with Alpha Energy Labs in Texas. So we tested radon this time. So our timeline, here's a timeline describing the progression of the Empower U study, which occurred very rapidly, like I said. In March 2021, Biomonitoring New Hampshire was approached by the USGS about a new risk model predicting uranium in New Hampshire groundwater and potential for collaboration on a project. A series of collaborations then occurred between USGS and CDC, our program in USGS, and then our program in CDC. We were then granted approval to move forward with changing the scope of our cooperative agreement and removing one targeted private well population study in lieu of this one. Much planning occurred over the spring of 2021, along with working on other grant deliverables. During this time, we worked on the Empower U exposure questionnaire, strengthening our assessment of occupational health exposures through collaboration with the New Hampshire Environmental Public Health Tracking Section. Environmental data analyst Nicole Carlson, who's pictured here with me at a New Hampshire mass COVID vaccination event at the Loudon Speedway. And this was the first time we actually met in person, even though we had been meeting virtually. So that was really exciting to work with her there. And our occupational health questions were also reviewed for accuracy and usefulness by the UNH Occupational Health Program. Study design and survey and material development continued over the summer while we again balanced our work with other grant priorities. Much groundwork was also done for this study, such as building the survey online for remote completion and getting an MOU in place for data sharing between the Division of Public Health Services and the U.S. Geological Survey. We received Institutional Review Board approval for this study late Friday, November 19th. We rapidly printed and packaged our recruitment letters and mailed 1,000 recruitment letters to every recruitment area, 1,000 altogether, 100 per recruitment area on Tuesday, November 23rd. Our first participants registered that Friday, November 26th, the day after Thanksgiving. 1 month later, we had recruited 184 people from 143 homes, with a goal, of course, of 200 homes for this entire project. This was a huge accomplishment and a huge feat for our very small program. Rapid recruitment was necessary to meet USGS's budgetary deadline of the end of the calendar year for water testing. So we quickly shared contact information for the first participating households with USGS for raw water sampling appointments. About a quarter of our households, 50, received paired water testing, so raw water directly from their private wells and also finished water from their kitchen faucet there. USGS funded the majority of the water testing for this project, which is estimated to be at approximately $180,000 to $200,000, which included sampling, testing, data analysis, staff time, etc. Test kits were prepared by Biomonitoring New Hampshire staff. The kits contained a letter, urine collection cups, water sample bottles, an air radon sample packet, instructions, and ice packs. Almost all of the kits were delivered by Biomonitoring staff to save on courier costs because it is quite expensive to utilize a courier. We did utilize the courier though for retrieving the kits and having them delivered back to the public health labs. The participants set up a collection day once the kits were received at their home. This page is just to remind you of our targeted recruitment areas and to emphasize how quickly, how rapidly we recruited for this study. So although we just officially closed recruitment with the IRB at the end of May, we had recruited almost 70% of our participants during the first month of the study. Also, it was holiday season and winter, which created some difficulties that we had to overcome. And you'll see a little bit about that in the video that I'll email to you later that Katrina describes, like issues with weather and icy roads and just issues with planning with the courier. So we were just so excited and proud of ourselves for how quickly we are able to recruit such a large percentage of our population. So on the next 2 slides, I will show you some really preliminary statistics. We're still in the testing phase, so we don't have much final data to share at this time. So our only restrictions for recruitment were that participants needed to be living in one of the 10 targeted areas. They needed to have a private well at home and be at least 3 years old, not institutionalized, meaning they weren't living in a hospital, a treatment center, or prison, and to be mentally capable of understanding the potential risks and benefits of this study. So we are happy with our close to 50-50 enrollment of both sexes, as well as the age distribution of our participants. Children are difficult to recruit for biomonitoring studies, and these types of studies are often biased toward an older population who just may have more availability to participate in something like this. So looking at the age ranges of the Empower You participants, we're able to recruit more children than in our 2019 surveillance study, the TRACE study. So we were able to recruit 23 kids for Empower You, but only 9 kids for TRACE. And that might be due to the more invasive nature of TRACE, where we collected blood specimens. Compared to 2020 New Hampshire census data, we know that about 18.8% of the New Hampshire population are less than 18 years old. For Empower You, we had 8.5%, so fewer. We also weren't basing our restriction or our recruitment guidelines on that. We were basing it only on like home address and making sure it was in our recruitment area. We know from 2020 census data that adults less than 65 make up 62.5% of our population. For Empower U, that age group is 61.3%, so that's pretty close. And then census data for New Hampshire adults over 65 are 18.7% of our population, and for Empower U, we're at about 30.3%. So, just some prelim stats there, and similar to other biomonitoring New Hampshire studies, our population is definitely largely non-Hispanic white, as is New Hampshire, but we will be in future studies trying to, make more of an effort, more of a deliberate effort to possibly oversample some of these other groups, or to just really make sure, especially for our next surveillance study, that it's these younger people for our other surveillance study, but also that these less represented groups are represented better in our next surveillance study. So just as a reminder, we sampled 199 homes for this study. We'll need to follow up with some for resampling due to various issues like improper sample collection. We experienced many issues with large air bubbles in the radon water collection vials, which means we aren't able to test them here at the New Hampshire Public Health Labs. Also, testing at the USGS water labs is still underway, so an update on metals and water will have to wait until our next TAC meeting. With funding from the New Hampshire Environmental Public Health Tracking Section, the New Hampshire Public Health Lab's Water Analysis Laboratory tested for lead in stagnant water and radon in water. EPHT also funded air radon testing, like I said before, which was completed by Alpha Analytical Lab in Texas. We have results for lead in stagnant water from 198 homes. Of those, 10, or about 5%, exceeded the EPA maximum contaminant level of 0.015 milligrams lead per liter water, and about 53% exceeded the EPA maximum contaminant level goal of 0. There's no EPA MCL for radon in water. However, there is a screening level of 2,000 picocuries per liter. For the 165 homes for which we have radon and water results, about 47% are above the screening level. Deciding whether to treat water can be informed by an air radon result. The EPA recommends that if water results are in the range of 2,000 to 10,000 picocuries per liter, then water should be treated if air radon concentrations are above 4 picocuries per liter. For air radon, we have results from 175 homes. The EPA recommends that homes be fixed if air radon level exceeds 4 picocuries per liter. However, there's no known safe level of exposure to radon. As you can see here, a third of the homes tested in this study are above 4. Additionally, there were various issues with 13 test packets, such as overexposure or missing information, and we do not have test packets from 11 homes. So we will be following up with those folks and offering some retesting. So with our final few minutes, I'd just like to get your thoughts on how we should start thinking about how we want to analyze this data that we've collected in this study. So we have information from the exposure questionnaire on demographics, the home, occupational history, recreation and product usage, food and beverage consumption, and health. We also have our biomonitoring results, or we'll have our biomonitoring results on about 16 metals and 6 arsenic species. We'll have water results on metals, radon, and other water quality indicators, and we'll have our air radon results. So I want to throw it out to you guys just for a couple minutes, and Melissa, please keep us on time. I'm not quite sure where we're at. We might be almost up, but we could just take your suggestions in the chat box if you have anything you'd like us to look at. I can definitely share these slides later so you can take a look at all those analyte lists again. Also when I share that really great video with you, and you can get back to us in that way. But if there's anything that's jumping out at you, I'd love to hear it today. And again, Melissa, please let me know how we are for time. We have 1 minute. Great. So if you have any thoughts, I'd love to hear it. I'll pause.
So Mandy, are there particular contaminants that Ayurvedic medicines are associated with?
Yeah, for sure. Some of the metals, right, like lead and mercury, and we have a whole list that we could go through. Is there something in particular you're wondering about?
No, it just, nope.
Okay, yeah, you just jumped out
Yes.
at you on that list. Yeah.
So Paul, we have tested some of those Ayurvedic medicine here at the New Hampshire Public Health Labs and found very high levels of arsenic, lead, and mercury.
All right, I want to keep us on time, so I will follow up via email. Go ahead. Is there one more question?
Yeah, I was just going to ask, I mean, is there a specific research question that you're asking of the data, or is this just trying to figure out sort of which way to data dredge out of all the analytes you're going to get back and all the survey questions?
Yeah, so for biomonitoring, we're still kind of exploring that. We're gonna inform our direction based on what we've seen in previous studies. But when we were approached by USGS about this study, they have their own research questions. So we're kind of just supplementing what they're looking into. Joe, I saw that you joined the call. Do you want to chime in real quick about exactly what you guys will be doing with the data? And then maybe we can talk about how this other biomonitoring and exposure data can help with that.
Sure. Thanks, Mandy. So one of the questions for us was this sort of increasing perception that uranium was a more prevalent contaminant than we had previously thought in New Hampshire and in private wells. And in particular, one of the reasons was because it appeared to be clustering more than we'd seen with other contaminants like arsenic. And so we wanted to test that hypothesis, and this study was designed, as you could see with the slide Mandy showed, with the 10 clusters of areas that we were working in. It enabled us to sample wells in ways that we hadn't done previously. Thank you. And rather than randomizing over a large area, we randomized within tighter clusters to try to look at the cluster effect. And as Mandy mentioned, we don't have all the data back yet, but it looks variable at the moment. It looks like in some places we are seeing clustered data, and then in other places, perhaps not so much. So a complicated thing, but a way to see if we're underestimating the exposure.
Okay, well, thank you very much, Mandy, for that presentation. And we will take a look at the chat. Is there anything in the chat that was missed? I haven't taken a look at it.
No, there was only one question, but it looks like Tyler and Nicholas answered that, so we should be all set.
Perfect. Thank you, Katrina. So moving right along in our agenda, I'd like to introduce the next presenters from the Healthy Homes and Environment section, Beverly Druin, the section administrator, and Gail Gettins, the developmental specialist and health communications advisor for the Healthy Homes and Lead Poisoning Prevention Program. Go right ahead, ladies.
Good morning, everybody. I'm Beverly Druin, and I'm here with Gail. We're going to spend the next 28 minutes giving you an overview of our program. Gail's going to do most of the presenting. Gail, ask me questions and throw it to me if and when you get stuck. Maybe we can ask people to mute their lines.
I'll see if I can mute people. Here we go.
Gail, you're on mute. Gail, we can't hear you.
Good morning. You'd think
Good morning.
you think 2 years into this, right? We would have this down. So good morning, everyone. I'm Gail Gettins, and I'm a child development specialist and a health communications advisor in the Healthy Homes and Lead Poisoning Prevention Program. And just as a quick overview, so everyone has an appreciation, the large part of the funding for our program comes from the Center for Disease Control and Prevention. And a big part of our program, which not all folks realize, is that all blood lead level test results, that all tests that are done on children, adults in the state of New Hampshire, all get reported into the Healthy Homes and Lead Poisoning Prevention Program by statute, where they're reviewed by our clinical team, our nurse case managers. So we start with this slide in almost every presentation to get folks' attention, if nothing else. Most people have little appreciation of the numbers of children that are exposed to lead, that have elevated blood lead levels each year, every year in New Hampshire. And between 2015 and 2020, we had 3,885 children. I mean, we're a small state. That's a lot of children with elevated blood lead levels greater than 5 micrograms per deciliter. And that averages about 500 children a year, each year, over and over and over again. And in fact, as if this slide isn't, if you will, bad enough, if you take out 2020, where the numbers were so much lower because of COVID and offices being shut and children not getting tested, the numbers are actually higher. It averages over 600 children a year. 2020, when you include it in the data set, just makes us look, if you can say better, it does. But we have a lot of old housing. We're one of the original 13 colonies. We have a lot of old housing stock, and we have a lot of children exposed to lead each year, every year in New Hampshire. And just another kind of foundational piece, all children in New Hampshire are required or mandated to have a blood lead level test at age 1, and again, a second test at age 2 by New Hampshire statute. That law creating us what's called a universal blood lead level testing state went into effect April 9th of 2018, so a little over 4 years ago. So each year, I shouldn't really say we, it's our talented epidemiologist, Robert Funa, pulls all our data and we create the lead exposure data brief. And what's on the screen is the 2020 lead data brief. And I'm going to pull a couple pieces from it that really stood out when we created this data brief. This data brief, and we also create regional data briefs drilled down to the by Public Health Network, and they're available on the data portal. So here are 3-4 slides of some of the data that was in the 2020 report that really bared attention or grabbed our attention. First, our children enrolled in Medicaid are not getting tested. I mean, to just cut to the chase. Our 1-year-olds in 2020 that were enrolled in Medicaid, 39% of them were not tested. And this wasn't a bad year. That has just been pretty much the status or the level at which they've been tested at for a great number of years. If it can get worse, it does. And the 2-year-olds are enrolled in Medicaid in New Hampshire. It's even more dismal, and that 49% of them are not tested. And basically half of the 2-year-olds enrolled in Medicaid are not tested in New Hampshire. There's been some slight improvement since 2017, from 42% up to 51% of the children are tested. But this test is the one that is so critical. Lead exposure in the United States peaks between 18 months and 2 years of age, predominantly because of their developmentally appropriate behaviors of putting everything in their mouths, moving around the home where there are lead hazards, and not having the 2-year-old test done. We are really missing an important test with a very important population. This was the other slide that's getting a lot of attention, appropriately so. And I think all of you are data wizards. You're going to see this it's pretty obvious here. But we test very few children enrolled in Medicaid. But in that small population, it's disproportionate that that's where more of our elevations are. not only more of our children over 5 micrograms per deciliter, but it's also where we see a much greater number of the very high elevations, or in this case, we use the marker of 10 micrograms per deciliter. So this is a population that we're not testing, but in the few that we do test, there's a much higher percentage of children who've been exposed to lead. There's clearly, this is an area that we need to put more time and attention on. The other piece in this data brief that's getting a lot of attention, appropriately so, is that 36% of our children in New Hampshire with elevated blood lead levels live in rural areas of the state. And we focus a lot on Manchester and Nashua and some of our other small cities that have historically had very high numbers of elevations and very low testing rates. But this was another important piece of data that really jumped out at us, that 36% of our kids are in rural areas that have elevations. So just an overview of where our trajectories have been. You can see since 2015, we've been on a positive trajectory. And certainly, though no one's especially proud of a 58 on a test, getting from 27% to 58% for our 2-year-olds really was a big success, though we have a long way to go. We expected this trajectory to just continue. And then, of course, the pandemic arrived. And like all routine screenings and immunizations in our pediatric population, they plummeted. Testing rates plummeted across the country. It wasn't just New Hampshire, but you can compare the blue line and red line are 2018 and 2019, and the green line is 2020. And 2021 wasn't a whole lot better, not necessarily because of the pandemic, but we had another issue with about an 8-month almost cease and desist stop with recall on testing supplies needed for point of care testing. But really what you need to take away from this graph is that between 2019 and 2020, so the year of the pandemic, comparing the 2 years, there were 3,108 fewer children tested in New Hampshire. It was a little over 14% drop in our testing rates, which of course was crushing after so many years of working to improve them. And a piece to just, point out is it was getting a lot of national attention. Testing rates plummeted. This is from about a year ago in the New York Times, but at the same time, we were seeing more elevations because children spent more time at home. Schools were closed, childcare centers were closed, parks were closed. Pediatric offices were closed or only seeing 6 children for months. So as a result, we had fewer children tested nationally, and we are also seeing a greater number of elevations. So just flipping gears a little bit to changes within our program. Last July, so almost a year ago, our public health action level dropped to 5 micrograms per deciliter. What is our public health action level? It's in essence set by the legislature. This had been a gradual lowering over the last few years since 2018 when the laws were passed or updated. And it means when we can put public health, if you will, boots on the ground. Now, since last July, any child that has a confirmed elevated blood lead level of 5 micrograms per deciliter or greater is eligible for our nurse case management services. Our nurses do a home visit. They do a lot of work with our pediatricians, often the voice between the home and the medical office, and making sure the child's getting all the additional support services and medical management and blood work needed. Our environmentalists can also go out and do a lead investigation in the home. We test the water, we test the paint, and they can kind of go out increasingly larger circles, like to grandmother's house or child care center, to find where the child is getting exposed to lead. And finally, it was a big change as well, because with the 5 micrograms per deciliter, if a child is living in a rental unit, with that blood level and the lead hazards are identified in the rental unit, then the property goes under order. It's a legal administrative process which requires the landlord to address those hazards. Children remain in case management until two criteria are met, until they're over 3, until their blood lead level is under 5. And they don't age out or they age out when they're 6. Our caseload has mushroomed since July. It's expected to continue to increase. No additional staff, from about 82 children a year to well over 300. We also send out parent letters or property owner letters, 2 different sets of letters. This is also part of the legislation as required by law. So if a child has a blood lead level of between 3 and now, because the blood lead level dropped to 4.9, so between 3 and 4.9, we send a letter to the property owner identifying them that we believe there's a child living in one of the properties they own with an elevated blood lead level and gives them background information. On the same criteria between 3 and 4.9, we send letters to parents indicating that their child has had this blood lead level, indicating that they should work with their property owner if they live in a rental, not start doing repairs themselves, and we give them additional information if it's owner occupied, if it's a family that owns and is living in their own home. We do a lot of work with our pediatricians, with our pediatric healthcare providers across the state. And one of the resources that we created about 4 or 5 years ago is our medical management quick guides. They're basically a desk reference for pediatric healthcare providers on when to test, when to do follow-up testing based upon different results, as well as clinical management of the children who have been exposed to lead. It also has other information in the set of 3 that are laminated, so it's wipeable. It can be in the exam room or on the lab counter or on a physician's desk. These are available on our website as well. And as they say, it's a hot seller. We can't produce them and hand them out fast enough. The last 2 pieces, one of the last 2 pieces I wanted to mention, because this has been wrapped into some of the work that you all have been doing and Mandy's been doing. If I say this is the best grant we ever wrote that wasn't funded, but in our last grant cycle of April of 2021, so about a year ago, CDC, if you will, kind of split and separated what had been our, if you will, longstanding lead surveillance report, excuse me, lead surveillance grant. And there was a component A and then a component B. And B was a separate piece for primary prevention, targeting high-risk populations. And for the first time ever, you were eligible to apply for areas with rural designations. So this was a first that we had rural areas and rural health, making it kind of onto the radar. And you were eligible if you were coupled with other health disparities. So we in fact applied, and we looked specifically at our North Country, which I don't think is a surprise to probably anyone in this group, with the health disparities and the high risk for lead exposure and low testing rates. But another area that really jumped out when we were working with our rural health program was Carroll County. So we also used our lead targeted outreach tool, which really shows some of our hot spots, our high risk areas for lead exposure, looking at a number of different risk factors, and also looking at the lead surveillance. So as I mentioned, this grant was not funded, which was disappointing, but we did come to learn that anyone who got grant the component A funded, which we did not get B funded. So that made us feel a little bit better, but still disappointed. But the good news is this grant and the material in it, the narrative especially, has been used not only by the biomonitoring program, but also Carroll County has just used a lot of the material. They've applied for an EPA Healthy Communities grant using a lot of the same information. So as we say, it's the best grant we ever wrote that wasn't funded, but it definitely brought us in touch with a lot of new partners on addressing some of the health issues and the lead issues in these areas. And finally, in my last minutes here, just to kind of end on a more positive or happier note, besides just large numbers of children exposed to lead and grants that aren't funded. Let's talk about something positive here as we wrap up. And we just want, if you weren't familiar with this, New Hampshire Division of Public Health Services and the Healthy Homes and Lead Poisoning Prevention Program, using CDC and EPA funds, has created a children's board book, Happy, Healthy, Lead-Free Me, with clinical support and strong collaboration from New Hampshire chapter of AAP. This is Christine Arsenault, Dr. Arsenault at Concord Pediatrics, handing out the book to one of her young patients. The book is geared to hopefully or does delight children with illustrations and rhyming text, but on each page there is parent education on the importance of pediatric blood level testing and how to identify and prevent lead, or identify lead hazards and prevent lead exposure at home. A big part of developing this book was beta testing or market testing. We tested it with 96 families across New Hampshire, as I say, from Swansea to Somersworth, from Nashua to Lancaster. And we tested both in English and Spanish with families. They had printed beta books, so early editions in English or Spanish, and the survey was also available in English and Spanish. Book is done out the door, and it is available in 6 other languages besides English. It's available in Spanish, Nepali, Dari, Chuckese, Swahili, and Portuguese. It's printed. We have printed editions in English, Spanish, and Nepali. So I'll end there, and we can be available for questions in whatever minutes that we have left.
Gail, can you go back to the map with the risk map, slide 24? Sure. Karen Craver has questions in the chat, and I don't know who here from Environmental Public Health Tracking is on the line and maybe can jump in, but Karen, this is using Dennis Holt's, I'm assuming this is using Dennis Holt's SVI data. And Taylor, you might have done this map. I don't know. But it is using the social vulnerability indices. So did you have something specific? Oh, Katie, great. Jump in.
Yeah. Hi, everybody. Katie Bush from the Environmental Public Health Tracking Program. I think that tracking made this map. And so for a number of years now, we've been working with the lead program to make what we call a lead-specific vulnerability indicator. So many of you might be familiar with our existing social vulnerability index that uses about 16 metrics from the ACS. And over a number of years, we've sort of refined that list of risk factors to be specific to lead poisoning through correlation analysis and regression analysis to come in on about 5 key variables that we think are really linked to lead risk. Things like, do you rent or own your home, number of children in poverty, percent of housing built before 1978 when lead paint was banned. And I'm forgetting right now, but it is a tool that we have used now in a number of the lead grant applications over the years to help identify high-risk communities across the state.
So I would add to that, so the shading is the risk, but if you look at the circles, the larger the circle, the lower the testing rate. So you have a really dark community with a huge circle, high risk, no one's testing children, right? It's, a shame. So Karen, did that help you out?
I think so. I was just trying to figure out. So the numbers are sort of the SVI scores.
Yep.
Under
for the shading. Yep, for the shading. And then the circles are the testing rates.
Okay, with the bigger circles being the lower testing
The bigger
rates. Yeah.
circles that are shaded, the lower. Yep. Yep.
Okay. Thank
So
you.
dark
This
towns
was-
with big circles are bad news.
Yes, this was created largely by Dennis Holt. It's been a really valuable tool for us.
Yeah, we've used it for easily 5 or 6 years. We've been using the SVI. Were there any other questions that we can help people with this morning?
Gail and Bev, thank you so much for this information. It's so much good information that I'm actually going to continue talking about it a little bit.
Well, I want to thank Gail because she's really the one who can explain all this. So thank you for having both of us. But Gail, thank you this morning.
Thank you.
Hey, I just wanted to say my hat goes off to you both. It must be really tough to deal with the increased workload of, obviously it's amazing news to have the action level lowered to 5, but it sounds like it's caused an increased workload without additional staff. And I just want to say I'm very impressed by, your continuing hard work and serving an ever increasing number of children with existing staff.
Well, it's on a trajectory to be about a 4 times increased workload. So it forces you to lean. It forces you to, we were fortunate to have a contract that we could put some of these families, help them with some contracted services. We did get a home visiting contract in the $25 million health equity contract, that health equity grant that the public health has, but it really forces you to evaluate the services that you're providing families. So, thank you.
Agreed. It's a lot of work for such a small number of people to have to pick up. So great job. And thank you again. And so I'm just going to add that we, in the biomonitoring program, also had Gail give this presentation to us back in February, and we realized that they had identified very specific testing needs in New Hampshire that we hope we can meet through our next study. Looking at lead and other metals in children. Our catchy study name is still needed, so ideas are welcome. I'm just going to give an overview, and then we'll have a discussion focused around questions that we still have related to the study design. We probably won't hit all of them just to make sure we don't go over on time today, but if we do have time, we will. So the study focuses on reaching children identified as having high risk for lead exposure and for not receiving lead testing. So those children receiving Medicaid and who are located in the rural areas of New Hampshire. We will be enrolling children ages 6 months and older. And we hope to be able to work with Medicaid to cross-reference a list of children enrolled in Medicaid with a list of children who have already been tested to narrow down our recruitment pool and specifically target high-risk children. Our recruitment goal is 400 participants, and as many of you know, and as Mandy pointed out, recruiting children for a study is incredibly challenging. So if a child is enrolled, we're allowing anyone in the home to also enroll. Participants will digitally consent and take an online exposure questionnaire. We're really excited to utilize our new mobile phlebotomy contract for specimen collection, processing, and delivery to the New Hampshire Public Health Labs. So a lot of services rolled into one. We'll be testing urine and blood for a number of metals. Each household will receive free water testing, and each participant will get a $25 gift card, possibly more. That's to be determined. Results and risk communication will be provided in a comprehensive report packet, and biomonitoring will be providing one of those beautiful books that Gail just showed you called the Happy Healthy Lead Free Me board book. And so really excited to be able to provide that resource to families as well. So here's a list of the clinical and water analytes we'll be looking at for this study. We're very excited to once again provide participants with free water testing with this study. Through a mini grant from the New Hampshire Environmental Public Health Tracking section, we'll be able to test water samples for a number of analytes. This water panel was decided based upon what would give the participants the most useful information, which analytes are of concern in New Hampshire and for this study, and what could be transported at room temperature in the mail. So a lot of things to consider for the water testing. This testing will give us paired clinical and environmental data for arsenic, lead, manganese, and uranium, allowing us to look at chemical exposure and body burden for those analytes. So moving right into the discussion part of this presentation. So we have a number of questions we're looking for which we're looking for your input. Feel free to speak up or put your comments in the chat. I mentioned that we're planning to enroll children 6 months and older. However, for reporting, reference values come from the CDC's National Health and Nutrition Examination Survey, or NHANES. The survey collects urine metal data for children 3 years and older and blood metal data from children over 1 year old. And so our first question really is, should we stick with this age group that we've provided here, 6 months and older, and have data that is not necessarily directly comparable to NHANES as a reference? Is it worth that? What are your thoughts? I'll give you all a minute to think and to speak up or put notes in the chat. And Katrina, I can't see the chat at all, so if there's anything, please just feel free to speak up.
Nothing coming in on my end right now.
Okay, no problem. So I'm going to move along. If you have thoughts or ideas that you think of later, please either feel free to throw them in the chat or shoot us an email later. We'd love your thoughts on this. Okay, so next question. What would be a good maximum age to enroll children? And so what I mean is, for a family to qualify, we want them to have a child in the home. Considering the risks of lead, is there a maximum age for a qualifying child, or should having a child less than 18 years old in the home qualify the household? So for example, is 13 years old too old to qualify for participation because their lead exposure is probably low? Again, I'll give you a minute to think and hopefully respond.
Hey, Melissa, this is Nick. Going back to the NHANES question, is there any comparable state studies looking at this kind of demographic age other than NHANES, or, I'm just trying to think of another comparison population.
I don't know. It's a good question. Something we can definitely look into, but that's a good point. If we want to get those really young children and we need a comparison population, and it's definitely something worth looking into. So thank you.
So
we do have,
go ahead.
Sorry.
I was just going to add in.
Yeah, go ahead.
Not many states have done surveillance studies yet, right? Many states in the current CDC cooperative agreement have proposed projects and are working on that. So we can look at possibly California. They were doing a surveillance study years ago before this current cycle. And we can try and look into other states and what types of data they've collected already. Like Minnesota is doing a surveillance study. I believe Michigan is. New Jersey is collecting some blood data using like mobile phlebotomy in clinics, and New York as well. So that's a great point. We usually just compare to like NHANES, but maybe there's another state that we could compare to. Thanks.
So I see Jonathan's got something in the chat that I think is a really good point. And it's unclear what the goals are. So if you, like for lead, we want to look at young children, but for some of the other metals, we might want to look at older children because they're drinking more water or what have you. So like, what are the overall goals of the study?
Yeah, I think it's to really meet the needs of programs that we work with, like Healthy Homes and lead poisoning prevention, and to meet the needs of New Hampshire residents. And so I think based on the 2020 lead exposure data brief, we really feel like there is this need for young children to be tested in rural areas and in who are enrolled in Medicaid. And we think, I guess that's part of our question is, what ages are important. We know that children, under 3 have very high exposure, but do children at 4, 5, 6, 10 have high exposure to lead? I think our focus here is lead because there is a lot of health concerns with exposure to lead, and so I hope that answers the question or provides a little clarity. Is that helpful?
Well, I mean, somewhat, I guess, because the question is if you're looking at other metals with this, are you trying to understand how those other metals may be co-exposures to children at those action levels, which those action levels are at a younger age group than what you can really compare to NHANES? But just now you said it's more about comparing across different ages. So you're getting away from those ages where we would be testing and making decisions at. So I guess it's really a question of, are you looking to do a study to inform exposure information around the ages that the blood action levels are basically acting on with that required testing? Or is this more of a broader question of how does this change over time?
So if I can jump in, there's a couple different things going on that we're trying to accomplish all at the same time. So ultimately, the CDC cooperative agreement funds states to just increase the capability and capacity of public health labs to conduct biomonitoring. So it funds us so we can bring on the instrumentation and the expertise and the people to be able to do this testing. And with that, we can do whatever we want with it. And so knowing we can do whatever we want and having like this method already in house from our previous cooperative agreement, and then knowing we have such a high risk population, we proposed this study that has changed over time. So initially, like the goal is just very broad, like use our methods, test people, see what's going on in our population, provide education. And then because we have the blood lead reporting requirement, it's like, okay, well, we have to report this data to Healthy Homes anyway. So what other information can we get? So we want to help them test the kids that aren't getting tested, but then learn more about those kids and their families at the same time. So it's just really broad.
So it would be nice if you targeted homes that had children at a minimum 6 and under, if not 3 and under. But with their exposure, you're right, it'd be nice to have adults in the home, older children in the home, because this study is not just children, it's everybody in the home, right?
Yes, because we want to look at other potential sources like take-home lead, right? Our parents,
That's
or maybe
right.
like adolescents who are working, bringing it home from their jobs.
Yeah.
This is Katie. I was going to jump in and say that is one of our biggest questions, research questions, is what are the risk factors and what are, the likelihood of co-occurrence of metals, and also looking at the different potential sources of exposure. So we know that household dust and paint are a primary route of exposure. We know that drinking water may be a secondary source of exposure. But then we know from clinical staff and the work in the lab that these different medicines and spices, and that's where we can start to look at the co-occurrence of some of these metals and start to understand, okay, we've historically tested for lead, but what other contaminants might be showing up in these people's bodies as a co-occurrence? So I'd say one of the overarching questions is to better understand risk factors for childhood lead. And by testing the entire family, we'll get a much better understanding of potential take-home lead, either occupational like sources or hobby type sources. And so from our side, as like the environmental health surveillance and epidemiology, those are some of the key questions we're interested in trying to help answer.
I'm going to move on to the next question in the interest of time. And actually, I'm going to skip a couple of them because we just won't have time to go through all these questions. And so if you have any thoughts on, other things we missed from that data brief that Gail gave, feel free to put something in the chat, just letting us know what you think, maybe if we missed something important. So a couple other questions I'm not going to touch on, but feel free to read them. And if you have thoughts, let us know. But I'm going to go to this last question because it really ties into what we were just talking about, which is, so looking at, children with elevated blood lead, is it important for us to include them in this study when we know that they have that elevated blood lead level? And I think there's two sides to that coin. They've already been tested, they have a value, they're in case management, their families may or may not be, deciding to have blood testing done. They may, I'm sure there's questions about take-home lead. But if we don't include them because they already have a result, we are missing an opportunity to test siblings or family members. And so we just want to know what your thoughts are. Is this something should we include, all children who, even if they've already been tested, or should we, maybe limit it to just those who have blood lead levels below 5, or, have never been tested at all? So what are your thoughts on that? In just a couple of minutes, I'm so sorry.
This is Beverly. I think my gut is to include them because you can learn a lot about their family and their environment and their patterns.
Thanks,
I think it can only benefit us.
Okay.
I would agree with Beverly, especially the siblings. There'd be a lot to learn.
Okay. Thank you. I apologize. I really wanted to have the whiteboard set up for this so that I could get, everybody just typing away and giving us your feedback so that we didn't have to, only use words in the chat, but I promise to be better prepared for that next time. So we'll move on. We did have one last question, and I will just throw it out there, and maybe you could give feedback in the chat or ask, maybe some follow-up questions we can answer about using either venous blood, which is, from a blood draw, or capillary blood, which is either from a finger stick or a heel prick. For this study, I will note that we do not have the current capability to do this testing. We would need to do a validation for capillary blood. We only have validation validated a test for the testing for venous blood. But of course, venous blood is much harder to get from young children. And it would really put back our study several months because of the requirement for lab staff. So your thoughts on that would be really great. And again, I'm sorry that this has to be cut a little bit short, but please feel free to email us or send us your thoughts in the chat. And
am I hearing our program owns a lead care 2 analyzer for capillary samples? Are you doing the analysis in-house?
Yeah, so we would be looking at a much lower level. Yeah, so those analyzers, though really helpful at point of care services, really don't get those low levels that we're looking for, and that includes the other metals that we mentioned for the blood testing. Does that answer your question?
Yes, there are, just for note, the newer lead care 2 ultras have a much lower detection level.
Okay.
That is not ours, but the newer ones. We discovered this when we started getting results reported from pediatricians' offices at much lower levels. We assumed there were mistakes, but it was not.
Oh, okay.
They had newer equipment. So
that's good to know.
Just as a sidebar. But,
take a look at that.
Just as a side, with testing results for lead, if we rely on a venous draw, it does not get done. I mean, maybe different in your families are kind of captured in your study, but with children, if there's an option to use a finger stick, I would just argue that you will have much greater success in general participation in your study, as well as just a cooperative child to actually get the sample that you need.
Yeah, and as a reminder, we will be sending phlebotomists to individuals' homes to do these blood draws, but you're right, you can't get a blood draw from a kid who is wiggling and squirming and fighting. So that's a good point. Thank you. All right,
Does it have to be either or? I mean, can you be prepared to go into a home and do both? Or you want it all one way or all the other?
It's more that if we do decide that capillary blood is the easier way to go and we want to bring that on board, it will put us back months. So we hoped to launch the study this summer, and we're talking about launching in probably the winter time if we were to try to bring on capillary blood testing. Okay, great. Thank you for that discussion. I think I've already stopped sharing. So we're going to keep moving through our agenda. I'd like to next introduce Sam Masato, a recent graduate from the UNH Master of Public Health program, to discuss the work she did with our program. So Sam, if you're on, feel free to share your screen.
Hi, yes. Let me share the screen here. And are you seeing my presentation at all?
We are, yes.
Okay, perfect. So I'll get started. I'll try to speed through this because I know we have the agenda to get through. So my name is Sam Masato. I recently graduated from the University of New Hampshire as I completed my Master's of Public Health. I was graciously invited here to present my final project that I worked with the New Hampshire Biomonitoring program with. So I was under mentorship of Amanda Kosser. We reviewed and discussed a few things to kind of build my project. She gave me some background on the biomonitoring program, their methods and procedures, and current successes and challenges. We went through the sample collection process and instructions of the sample kit, the water sample kit collections. And then also we went through some risk communication and plain language training. I did meet with her weekly to discuss the project. And I will get into more detail on the actual project before. I just wanted to essentially give like a broad background. So it revolved around two aspects or deliverables. And the first one being qualitative feedback on water sample collections instructions. And then the second being standardization of risk communication templates. So the goal of the project was to reduce and prevent chemical exposure in the New Hampshire population by improving the accuracy of testing results. This would be done through the water sample collection deliverable, and then also increasing education to the public regarding health risks exposure and prevention methods, which would be achieved through the risk communication templates. So the two deliverables, I kind of went into a little more detail here. To complete the aspects, the water sample kit was sent to me, and I was able to test it out. And I created a flyer seeking volunteers to test the water kit and provide feedback on the instructions via a survey. To complete the risk communication templates, I researched, analyzed background information and some prevention measures to create the template that could be used internally by the New Hampshire Biomonitoring Program when contacting participants. I discussed with Mandy on what info should be included, and she reviewed them, and I made revisions based on her feedback. I presented this project to the annual Public Health Association conference in April, and I'd like to take you through my academic poster because I think it provides a great snapshot of the project that just in a very short way. So let's see if this will work. Okay, are you seeing the poster?
Yes.
Okay, perfect. So I'll just quickly go through here. Just a little background. I know you are all well aware that water testing is a useful tool in prevention of chemical exposure and the fact that chemicals really have no odor, taste, or smell, making them difficult to detect. In New Hampshire, there's certain geographical and geological and infrastructural components of the environment that can make residents high risk of exposure. As I said before, I partnered with the New Hampshire Biomonitoring Program, whose goals are to understand and test for which chemicals are getting into people's bodies and track those trends that can influence public health policies. The project consisted of the two parts. The first, focusing on improvement of water quality data by assessing the weaknesses of the sample collection process. And the second is the standardization of health risk communication by the New Hampshire Biomonitoring Program by creating a template for result dissemination and exposure prevention. So I'll just quickly go to the focus. the focus of the project was quality improvement for biomonitoring of chemicals in New Hampshire. In combination of my two aspects and deliverables of the project, the goal was to reduce and prevent chemical exposure in the New Hampshire population by improving the accuracy of testing results. This would be by increasing comprehension on how to collect and submit a viable water sample, and also increasing education to the public regarding health risk of exposure and prevention methods. And this would be through the development of the risk communication templates. So for my methodology, I did go into this a little bit before, so I'm not going to go into too much detail, but for the water sample collection instructions, I developed a poster or flyer seeking volunteers to test the collection kit and provide qualitative and quantitative feedback by means of a survey. The volunteers were asked to submit a photo of the radon collection tube within the kit. This is so that I was able to determine if they were able to collect a viable sample. In total, I put approximately 35 flyers in. They distributed them in multi-apartment buildings, grocery stores, and places of work. This was mostly concentrated in southern New Hampshire. And however, only 8 volunteers were able to complete all of the processes where the sample collection kit, the submission of the radon collection tube photo, and also the survey. For the risk communication analyte templates, I just discussed the objectives for their use with Amanda at the New Hampshire Biomonitoring Program, and from there I created them using plain language in a PDF format. So the results, the interesting part. So the results, I'd like to start off with just the charts you can see here. I included some statements from the survey where they had an open-ended option to provide feedback. And they were some statements saying that there were not too many graphics and one graphic was very confusing and I'd like to refer to pictures. So there was a lot of open feedback about graphics. However, when they had just a statement where they were to rate their agreements on a scale of strongly disagree to strongly agree, majority of participants rated that they agree or strongly agree that the instructions were easy for them to understand, and they agreed or strongly agreed that the visuals or graphics were visually easy to follow. Even so, only half of the participants were able to collect a viable radon sample. And then, so for the risk communication template, these were just created in a PDF format, 2 to 3 pages in length, and I'll show you these a little later, and with those key headers. Discussion, the radon collection tube was used as an indicator for instructions comprehension because they were visually easy to determine if the sample is viable by examining the presence of air bubbles. Interestingly, I was receiving opposing qualitative and quantitative data. So although most of the participants rated that they agree or strongly agree that the instructions were easy to understand, only half of them were able to submit a viable sample. The open-ended question portion of the survey did offer some insight as to why this may be. A lot of them had revealed that they thought the addition of improvement pictures would be helpful, and also there was some confusion on the number of papers within the kit. The risk communication templates were used using plain language. However, I did not observe them in use, so I don't know how helpful they will be if they are implemented. I'm going to go into the recommendations back to my in my PowerPoint, but I'll just quickly show you. So this is kind of an example of one of the templates that I created for with those key headers, and this will be sent to you as well. I can send this all to you. Okay, so I thought it'd be useful to put some other qualitative feedback from the survey. I thought the open-ended questions of the survey did provide a lot of good feedback, and this is what drove my recommendations. So I put just 3 of the questions that the statements that the participants had to rate from strongly disagree to strongly agree. There was a lot of mentioning that the instruction pages were a bit overwhelming and they had wanted a different layout. They thought it was a little bit cramped. Although they thought that the length of the instructions, the majority of participants did agree the length of the instructions were appropriate. And they were confident in their ability to collect a water sample instruction or water sample, but again, they mentioned that some of the figures were a little bit confusing. So from here, some of my recommendations. So for the sample kit collections instructions, I think based on the feedback from the survey, the addition of more graphics would definitely be useful. And I think you could even extend this a little bit further to create an online video demonstration on how to collect a proper water sample. I think Mandy mentioned that you had a YouTube channel. This could be linked in the instructions or how to find in the instructions so someone could visually view it. And also maybe condense the number of papers within the kit or clearly label the instructions for each test. For the risk communication template, right now they are just for internal use by employees, but if you could alter them so that they could be shared as supplemental information to participants, that would be awesome. And also I would like to kind of have more time to gain feedback from employees and the participants and make changes to the templates as necessary. So I just want to thank my professor at UNH, Carla Armenti, and Amanda Kosser at the New Hampshire Biomonitoring Program. And I am done with the presentation, the short version of it.
Thank you, Sam. That was great. I'll give everybody just a moment. If anyone has any questions, I'll let that set for just a second while I load the next presentation. All right, well, thank you, Sam, so much for taking time to present to our group today. We really appreciate it.
Yes, thank you.
Okay, so the last presenter today is one of our biomonitoring toxicologists, Carlene Snow. I almost said Dingman, Carly. It's been so long and I still want to say Dingman. She'll be giving some program updates and fill you in on some other work happening in our program. And currently I'm getting an alert. Okay, can everybody see the slides?
We're at the end, apparently.
Oh, let me try again, sorry. Sorry, Carly. Almost without a hitch, almost. Okay, let's try this again. Did it do it again?
Yep.
All right, we're just gonna, sorry.
That's okay. Perfect. Good morning, everyone. I'm Carlene Snow. I'm one of the toxicologists. I run the instruments that gather this awesome data that we're able to provide with you. My name is Carlene Snow, and I am one of the analysts for the Biomonitoring New Hampshire program, and I'm going to be presenting our program updates and other work session today. Next slide.
I swear I'm trying, it's not going.
It's okay.
Okay.
Perfect. Thanks. So we're going to touch on a couple topics, some staffing updates, our APHL fellowship projects, the Plymouth State University undergraduate intern project, validation of new methods, developments to current methods, and quality assurance. Next slide, please. All right. There have been many exciting opportunities in the past year, both externally and internally, for biomonitoring staff members. We would like to welcome Dr. Madhumita Chatterjee back to the biomonitoring program as the new chemistry program manager. Madhu is a former biomonitoring lab staff member. She's been a part of the chemistry program here at the New Hampshire Public Health Lab for the past 19 plus years. Madhu has gracefully filled the shoes of Dr. James Chitlin, our former chemistry program manager. James has taken on the new role of deputy director at Wadsworth Center, which is a research-intensive public health laboratory of the New York State Health Department. The Wadsworth Center is a staple in the public health world and provides many services, including but not limiting to proficiency testing programs. The next new addition to the Biomonitoring New Hampshire program is Betsy Wallace. Betsy has been here for 20 plus years in the Public Health Emergency Preparedness Unit of Chemistry. In 2 weeks, she'll be transitioning over from what we call LRNC to biomonitoring as the new lab supervisor. With all of Betsy's experience with the instruments that we run here in the lab, biomonitoring is incredibly fortunate to have her aboard our program. Dr. Kimberly Aviato has moved over to Food Chemistry Unit. She is the former lab supervisor. She's still providing continuing support for the biomonitoring lab staff as we transition over and get situated. In the meantime, Amanda Kosser has been instrumental as our interim lab supervisor. She's also taken over the role as the principal investigator of both our Biomonitoring Cooperative Agreement Grant, as well as the Independent Review Board applications for study oversight. This role can't go unfilled and was to be vacated when our beloved lab director, Dr. Christine Bean, was granted the Chief Learning Officer position at APHL. Chris, who is dedicated to the workforce team here at DPHS, is now leading the way in public health laboratory workforce. And this momentous opportunity that she has taken has already come full circle, as 2 fellows will be joining Biomonitoring New Hampshire to contribute to the great work that we do here, thanks to the APHL fellowship opportunity. Next slide, please. The APHL Fellowship Award was announced in September of 2021. The Association of Public Health Laboratories was awarded a $282 million grant over 5 years by the CDC to help strengthen the capacity of our nation's public health laboratories. The Public Health Laboratory Workforce Pipeline Project will increase the number of qualified personnel by expanding training opportunities, building up the existing APHL CDC fellowship program, and launching a new internship program to enhance laboratory capacity now and in the future. Next slide, please. Biomonitoring New Hampshire applied for 2 APHL fellowships for these proposed projects that you see here. We were graciously granted both. Applicants are currently being interviewed and will be anticipated to start this summer. The research priorities for speciated arsenic and mercury, which you can see here as the title being Biomonitoring of Speciated Arsenic and Mercury to Assess Environmental Exposures in New Hampshire, is going to be to establish a new public health specimen bank donated from participants of the TRACE and Empower You studies to support the generation and integration of high quality environmental and public health data sets, including biomonitoring data, environmental testing data, epidemiological assessment data, health indicator data, and infectious disease surveillance data. This is to investigate the distribution of toxic mercury species in New Hampshire by performing mercury speciation testing on blood specimens from the 2019 TRACE study and future biomonitoring projects, and to improve understanding on the distribution of toxic forms of arsenic among both the general state population that was sampled during the 2019 TRACE study and the high-risk populations investigated during the 2016 to 2018 targeted arsenic and uranium study. The second project that was proposed was linking biomonitoring and community science to assess exposures to air pollutants in New Hampshire. The research priorities that are associated are to investigate the PAH exposures in this vulnerable community by performing clinical biomonitoring of community residents, to engage the Berlin, New Hampshire community with air quality monitoring through the deployment of a community science air sensor project, and to investigate links between air quality data and PAH body burden. Next slide, please. Another exciting opportunity that we have in biomonitoring is that we have a Plymouth State undergraduate intern project that will be starting this summer. Meet Victoria. She's our new intern. Victoria will be helping with a number of risk communication projects. She'll be editing and reformatting the internal fact sheet that was created by the UNH MPH student, Samantha Musato, into public-facing documents. We hope to share these in a variety of ways, including on our webpage, with reports, via email, at public events, etc. She will assist with communicating elevated environmental and clinical results with participants so that the participants can take action to reduce their exposure ahead of receiving their final lab reports. And she will be evaluating types of data that's collected from the Empower You study and making recommendations for visual data visualizations, in particular heat maps that can be created using ArcGIS, and developing social media posts on biomonitoring and environmental exposures such as risk reduction, and et cetera. Next slide, please. Validation of new methods. We have 3 of them. The first one I'll go over is the volatile organic chemicals method. This is a method that we test in whole blood by GCMS. It's for low-level detection of VOCs, and we'll be doing that in both the upcoming Berlin and 2024 TRACE studies. VOCs are present in a wide range of sources such as fuels, solvents, paints, furniture, personal care products, and you can see the 11 analytes that are listed here. I would like to note that we appreciate all of your help in deciding which of the analytes should be included in this list. That was something that we discussed at one of our previous TAC meetings. And again, we appreciate your feedback on this. Next slide, please. The second method that we will be validating is the polyaromatic hydrocarbon metabolites method. This is tested in urine by LCMS. This method will also be used in both the Berlin and the 2024 TRACE studies. This is one of the APHL fellow projects. They'll be helping the biomonitoring staff get this method online and developed. You can see the analyte list there. I'll note that PAHs are air pollutant byproducts from the combustion process, such as wood burning, smoking, automobile exhaust, etc. And the major sources of PAH in the environment include those, but are not limited to, and the sources that I just mentioned, as well as municipal or industrial waste incineration. These compounds bind to particulate matter in the air. The main route through which they enter the body is inhalation. Although PAHs can also be present in food and ingested. The analytes that are listed here are the metabolites of the parent compounds naphthalene, fluorine, phenanthrene, and pyrene. And they are so sorry, I lost my spot. I'm going to move on. I'll come back to it. Thank you. Next slide, please. And the third method that we'll be bringing on is the validation of mercury speciation. This is a method that's run in whole blood. It can either be done with GC or LC that's in tandem with ICP-MS to allow the low-level detection of mercury species for both, again, our Berlin and 2024 trace studies, and will also be an APHL fellow project where they take the lead to help the biomonitoring staff bring this method on board and validate. Generally, total blood mercury exposure is mostly due to the dietary intake of the organic forms, particularly methyl mercury. Urinary mercury is mainly comprised of the inorganic mercury form, which is due generally to dental amalgam containing the element mercury and occupational exposures. Other known sources of exposure include various skin creams, Ayurvedic medicine, and so on. Mercury has toxic effects to the brain, kidneys, circulatory system, intestines, skin, and eyes, and can cause long-term damage. Bringing on this method for speciated mercury was also a result of the feedback from a TAC meeting that we had in the past. And we would like to thank you all again for being a part of Biomonitoring's Technical Advisory Committee, as your input really does matter to us, and we appreciate your time and efforts. The 2019 TRACE participants did have a higher total mercury than the general US population. So bearing that in mind, we are interested in bringing on mercury speciation to determine if these numbers are from food consumption and alternative environmental exposure or something unexpected. Next slide, please. The developments to our current metals, as you can see, the metals methods that we run are on the ICP-MS instrumentation that you saw on a previous slide. We have 3 different panels and have made some improvements to these methods. The first of which is our blood metals method, where we increase the equilibration time for oxygen mode from 10 seconds to 30 seconds. This stabilized our internal standard for the respective analytes and will improve the precision of our blood metals method. And we also received confirmation from our IRB that we still have approval to start an anonymous urine donation collection event for our urinary metals method. This will be used for both blank analysis as well as the production of in-house QC production, which I'll go over a little more in a following slide. There have been no recent updates to our arsenic species method at this time, but I will just quickly go over what the acronyms are that you see on the page here. The arsenic species in urine that we monitor are arsenic 3 and arsenic 5, as well as their metabolites, which are diethyl arsenic acid and monomethyl arsenic acid, as well as the non-toxic organoarsenics, which are acetylcholine and acetobutane. Next slide, please. Additional methods that we run are on organic contaminants. These are done on the LCMS method as they are non-volatile. The updates that we have recently done to PFAS are really exciting to us. There have been potential concerns that there could be a highly exposed targeted population with elevated concentrations of PFAS that are above the range of what our method can measure. So Biomonitoring New Hampshire underwent a dilution verification. This verification allows our PFAS method the increased capability to reliably test samples that have undergone a 40x dilution. Our previous dilution capability was only 5x. So we will now be able to analyze this population, and we also purchased highly accurate low volume syringes to use during the preparation of our calibration standards, which will improve the precision of our PFAS method. Other exciting updates to our methods is in February of 2021, we had new LC pumps installed. This is to transition the pesticide metabolite method from an offline solid phase extraction to an online solid phase extraction. This transition will decrease sample prep time by nearly half a day. It increases the automation for improved analytical consistency and will decrease the sample volume down to 0.2 milliliters from a full milliliter, which will leave additional sample volume for repeat analysis as required. Additionally, we have decided to expand our calibration range due to the repeat analysis that was required during the 2019 trace surveillance study, as many samples required dilution for reporting. Our previous method only went up to 6 ppb for 3-PBA and paranitrophenol, which regularly had up to a 25% retest quantity. This has now been increased up to 12 ppb to capture those analytes higher concentrations so that we don't need to do retesting. This was an update that was previously intended to the pesticide metabolites updates were previously intended to institute and have done as mentioned in our previous TAC meeting. We have since started this process and are still in progress based on our current needs for our program, but things are going well so far. And our other method that we have that we run on this instrumentation is serum cotinine, which is a metabolite of nicotine. And again, there are no updates for this method at this time. Next slide, please. The final component that I would like to discuss is our quality assurance program. There are two main components to this, the first of which is proficiency testing. The New Hampshire Public Health Lab is required to participate in third-party proficiency testing programs for all of our methods through various institutions. This is to maintain our CLIA certification, and due to the response from COVID-19, the CDC was unable to provide their BQASP PT programs, of which we participate in both PFAS and pesticide metabolites. This posed a problem where we no longer had a PT to keep our accreditation for the pesticide metabolites method, as they are the only PT program out there for these particular analytes at this time. Due to that, the New Hampshire Public Health Lab had to create an internal PT for this method, which we also have to do for cotinine, as there are no proficiency testing programs available for that as well. We will be having our biannual CLIA inspection this fall and are preparing for that. The other component of quality assurance that keeps our testing requirements in check are our quality controls. These are independent materials that are analyzed with every analytical run on every method to ensure accuracy. In the past, Wadsworth in New York provided us with QCs for our urinary metals panel. They are no longer providing this as a service, and we will be taking over the process of preparing in-house QCs for this method. We have started the urine collection process, which I mentioned previously, and that's well underway and will be used for both blank analysis as well as the preparation of these QCs for this method ongoing. As for the rest of our biomonitoring lab methods, we continue to follow a strict quality assurance plan to ensure that the data that we provide to you is accurate and precise. Next slide, please. I would like to take a moment to thank you. This is our Biomonitoring New Hampshire team. We have Katrina, myself, Amanda, and Melissa. And I would like to also just ask if anyone has any questions before we move on to our final session today, which is the group discussion. No? All right, Melissa, I'm going to hand it back over to you. Thank you so much.
Okay, thanks, Carly. And I'm just probably gonna do exactly what I did with Carly's slides and end up at the wrong end of my PowerPoint, but we'll give it a shot. So moving into, oh, not as bad as I thought. Moving into the last portion of our meeting today. I cannot get these slides to advance. Here we go. Okay. So this is your opportunity. We're really wondering, we want to hear from your program. We want to hear from you. What's new? What's interesting? Are there opportunities to collaborate? Tell us about what's going on with you guys, and I will. Let me put these questions up here. I know Karen Craver from the DES Apple Tree Grant has a new resource she wants to share. So Karen, I'll ask if you want to start the discussion.
Sure, I'll go ahead and start. And I really want to give credit to Rob Thistle as our PI of the Apple Tree Grant and call out that, the work that we do is in partnership with DPHS. So there's lots of people involved. So one thing that I just wanted to share with everyone is that the team just put out a new environmental health resource guide. And it was developed through a contract with Dartmouth, and it's aimed at sort of guiding local leaders. And we did actually get input from members of this technical advisory committee. I'm not sure if Kim McNamara is on the call, but she participated and provided input, as did others. But it's aimed at sort of directing people to the right program within the state, whether it's at DPHS or DES, depending on the environmental health concerns that they have. There's a 10-minute training that goes along with the guide to sort of introduce it and walk through a couple of examples of how to use it. And I would just invite, again, want to give credit to Rob and invite him to share a couple of words about it if he'd like to.
Thanks, Karen. I think you covered it. We can put the link in the chat, but it's free to use, and I encourage you to check it out. If there's anything you see that's errant or you want to make in addition to it, just let me know offline.
Do you guys want to show it on the screen real quick?
Sure, I can. Let me see. Let me make sure that I can. I just put the link in, and I'm just trying to, let's see. Sorry, I'm having a hard time pulling up the right tab. Can you guys all see the guide there?
Yep, you got it, Karen.
Okay, perfect.
Yes,
so it starts
little itty teeny beeny.
Yeah,
weeny.
yeah. I'd encourage you to use the link that I provided to take a
Okay.
look, and you'll be able to see it more. But there's a cover page that provides a little bit of background information, and then you can see here it sort of starts broadly on the left with a broad topic area, and then narrows the concern as you move to the right, and then links to state resources and additional resources, which include, federal partner resources. So like I said, there's also, I think I just put the link to the guide, but there's a 10-minute training, and you'll see some familiar faces, including Judy Reese from the Cancer Registry, that, to walk you through use of the guide. There is an additional training on environmental contaminants that will be released soon. That was part of the contract, and we partnered with the cancer program. Thanks, Rob, for putting that link in there. We partnered with the cancer program on this project, and they'll be putting out a module that explains cancer cluster investigations. And I can see Megan, I forgot that Megan was on this call. Hi, Megan. She was really helpful in developing these tools, and she stars in the second module, which is yet to be released.
You're on mute, Melissa.
Yeah, I'll jump in now. Melissa's screen got frozen. Sometimes that happens when we have large meetings on Teams here at Public Health. So thank you so much for sharing that that tool, Karen and Rob. Like, such great work. I know there were many hands, many players involved with that, and we are excited to be able to help a little bit too. So yeah, we're excited to, you know, share this great news of what you guys have accomplished. So we only have about 6 minutes left now. Oh, Mary, go ahead. I'll let you jump in first. Go ahead.
Hi, thank you. I just wanted to, let me pop the camera on too. Sorry, big head there. I wanted to thank you all. This was really helpful. I thought all the presentations were very helpful. It's great to see all the work that's being done there. I just want to echo what I think was going on in the chat, though. If we could, I don't know if there's, people may not be able to do a 3-hour meeting, but if we did a 2-hour meeting, if we could increase the time to 30 minutes on a presentation with 20 minutes for the talk and 10 minutes to actually provide feedback, because there's such great work you guys are doing and so many minds on the call that have different perspectives that I feel like we're buzzing through and we can't actually give you the kind of feedback that you need and that we can actually provide in that amount of time. So just if that's helpful, hopefully for the next meeting, so that we can all feel really good about what we're doing and providing as a service to each other and all of that. That'd be awesome. Thank you.
Yes, thank you so much. Thanks for bringing that up. We definitely want your feedback on how to make these meetings more useful, and oh my gosh, your feedback on the studies. That's really what we're looking for, right? So every time we go to plan one of these meetings, we're like, what have we accomplished? Like, let's tell them everything. But you're so right. Like, maybe we need to increase the frequency and we just talk about a couple things. I'm thinking about the lead program and how often they have their meetings, maybe 3-4 times a year. Minnesota has 3 TAC meetings a year. If you guys don't think that is too much pressure on you and your schedules, then it sounds like we should move towards something like that. So we'll be in touch. Maybe we'll poll or something like that and have at least 2, maybe 3 meetings a year that are maybe shorter. But thank you so much, John and Mary and everyone who's kind of told us similar things this meeting. Does anyone else have anything they want to, give us feedback on right now? Any other points they'd like to make? We will be following up with an email. We'll follow up with the questions we asked during this meeting and, presentations and whatnot via email. But if there's anything else you'd like to bring up now, we'd love to hear. Okay, it sounds like not at this time. I know we've been talking nonstop and you guys have been listening for about 2 hours, and that can be a lot. So thank you so much for joining us this morning. We will follow up soon with the information and questions, and we appreciate all your feedback and look forward to hearing more. Hope you all have a great day. Bye-bye.